Hello to everyone. My name is Maria Tzalonikou, and on behalf of the European Society of Skeletal Radiology Webinar Organization Committee, I welcome you all to the 4th ESSR webinar and to the first webinar of 2019. Today, it is my great pleasure to introduce you Professor Lennart, coming from the Department of Radiology of Ghent University Hospital in Ghent, Belgium, and who is also currently the chairperson of the ESSR Arthritis Subcommittee. The topic of today's webinar is MRI imaging of the pediatric knee. As it is used, we are going to start with a case presentation, which is going to be done by Dr. Bert, Degrieck, also coming from the Department of University Hospital in Ghent, Belgium. At the end of the lecture, please stick around, since there will be chance to ask questions to the speakers. Thank you all for being here with us, and please, Dr. Degrieck, you can start.
Okay, thank you very much. Hello, everybody. My name is Bert Degrieck. I'm a radiology resident in the University Hospital of Ghent. And the case I'm going to present today is about a pediatric knee. It's the warm-up case that you've all been sent already some information some days ago. So, our patient is a 10-year-old boy who is a very talented soccer player, and he's training very hard because the new soccer season is coming along, and he starts to complain of pain in the right knee. He mentions having suffered minor trauma 3 weeks earlier, and the clinical examination was normal. So the patient was referred for an X-ray, which we see here. So this is a detailed view of the medial femoral condyle, and we see that there is a bony defect with an irregular delineation of the cortex and multiple nodular opacities with surrounding lucencies. Based on this image alone, there is a broad differential of possible diagnosis. Maybe this lesion is a post-traumatic lesion, as the patient mentioned having suffered trauma earlier. The patient is also an active athlete, so maybe the lesion can be attributed to overuse. Other causes, such as infection and inflammation, also can be ruled out based on this image alone. But maybe it's just a normal variant, and maybe we're just worrying about nothing. So an additional MRI of the knee was made shortly after the X-ray for further differentiation. Here we see the sagittal PD image of the MRI examination, which shows that the lesion is located in the posterior third of the medial femoral condyle. The lesion is generally low in signal intensity on these PD-weighted images, with some foci of high signal intensity. Now, based on this image alone, it might appear as if we are dealing with a case of stable osteochondritis dissecans. If that would be the case, that's very bad news for our athlete, because treatment would involve 3 months of non-weight bearing. So we have to be sure and see if there is not another diagnosis that can fit the bill. And for this, we need to have a look at our fat-saturated T2 weighted images. Here we have the fat-saturated T2 weighted images, which show that the lesion is a bit harder to appreciate than on the PD weighted images, but very importantly, we see that there is no bone marrow edema present. This rules out osteochondritis dissecans and also other traumatic, infectious or inflammatory pathologies. And this confirms our suspicion, namely that we are dealing with an ossification variant of the femoral condyle. Now, the orthopedic surgeons did not believe us, so they prompted a follow-up MRI of the knee in order to further document the lesion evolution. The patient was re-imaged 2 months and 12 months after the initial examination, and we see that the foci of high signal intensity, which represent ossification centers, grow, and they coalesce with each other and with the already ossified part of the femoral epiphysis, and we see that the lesion is gradually on disappearing, which is a completely normal finding in this case of a normal ossification variant of the femoral condyle. So these normal variants can be seen most typically and almost exclusively in the posterior third of the femoral condyle. A very important feature is that they lack bone marrow edema and that the overlying physial cartilage is intact. It is quite a common variant. It can be seen in up to 22% of children with a male predilection. And the good news is that they are asymptomatic and that they regress spontaneously. And the bad news is that they can mimic osteochondritis dissecans on imaging. There are 4 subtypes of these ossification variants, namely the puzzle piece configuration, where we see a defect in the posterior third of the femoral condyle that is filled in with an ossification center that has taken the shape of the defect. The partial puzzle piece configuration is a variant where we see that the defect is only partially filled up with an already ossified center, but there is still a non-ossified component present as well. Another subtype is the spiculated subtype, where we see spiculated growth coming from the already ossified femoral epiphysis extending into the physial cartilage. This results in an irregular delineation. And the 4th subtype is the extra ossification subtype, where multiple ossification centers can be seen that gradually grow and coalesce with each other. Also, prior stages can be seen on MRI. In cases of a pre-ossification center, this presents as a sharply delineated zone of a high T2 signal intensity in the posterior third of the femoral condyle, as can be seen here. This then evolves into an early ossification center, where we see that this zone of high T2 signal intensity is much larger, a bit more hazy, and not so well delineated. Now, what's the difference between the normal variant of femoral condylar ossification and osteochondritis dissecans? There are some changes, some differences that are very important to see. Namely, the normal variant of femoral condylar ossification is not seen in children over the age of 13 years, whereas osteochondritis dissecans is not seen in children below the age of 8. In the femoral condylar ossification variant, there is still a lot of physial cartilage present, whereas osteochondritis is seen in cases where there is only a little residual physial cartilage present. The normal variant is almost exclusively seen in the posterior third of the femoral condyle, whereas osteochondritis dissecans typically takes place in the middle third of the femoral condyle, though there can be some overlap between both conditions based on location alone. A very important feature is that there is no bone marrow edema present in cases of the variant ossification, and however, it is almost exclusively seen in it's always seen in cases of osteochondritis dissecans. So MRI can help to differentiate between these two entities, as we have an example here. In the first case, we see a lesion located in the posterior third of the femoral condyle, and on the T2 weighted images with fat suppression, we see that there is no bone marrow edema. Also, the overlying physial cartilage is intact, so this is a normal variant. However, in the second case, we see that the lesion is located in the middle third of the femoral condyle. There is surrounding bone marrow edema, and there is a defect in the subchondral bone plate. So here we are dealing with osteochondritis dissecans. If you're still in doubt which entity your ultimate diagnosis will be, another useful tool is looking at the lesion angle. If you look in the coronal planes, a femoral condylar ossification variant typically presents as a small angled wedge-shaped lesion, whereas osteochondritis dissecans presents as a wide-angled and broad-based lesion. And if you measure the angle of both lesions and you use a cutoff value of 105 degrees, you can differentiate between the two entities with great certainty. So, in conclusion, femoral condylar ossification variability is quite common. It's actually very common, and it's important to be aware of that the entity exists. MRI can help to differentiate this entity from osteochondritis dissecans, namely if the lesion is located in the posterior third of the femoral condyle, if there is no bone marrow edema present, if the overlying cartilage is intact, and if the lesion is a small angled wedge-shaped, has a small angled wedge-shaped configuration on the coronal images, we're dealing with a normal ossification variant and not with osteochondritis dissecans. And recognizing this ossification variability as a normal finding prevents unnecessary treatment for your patient and may save your patient's soccer season. I thank you for your attention.
Thank you very much, Dr. Degrieck. That has been a very interesting case and definitely an impressive case analysis. So I would suggest now that you pass on the microphone to Professor Jans so that he can start over his own presentation.
So, good evening, everybody. Thank you very, very much for being here still at this time of the day. So, I will be discussing MRI of the pediatric knee with you. And so, as we all know, children are not small adults. So, there's differences that we need to be aware of. Children have weak physis and apophysis. Of course, there is normal growth in these children. And because of this, they do have normal variants that we need to know just as well. So a lot of lesions may be seen in the pediatric knee, all of which may need MR imaging. So of course we have acute trauma, which is probably most seen. We have the overuse injuries, but also infection may occur. There can be tumors or even inflammation, and sometimes we have congenital or metabolic diseases. And all of these causes may lead to lesions of the pediatric knee. And for us as MSK radiologists, it's really important and mandatory that we can depict normal ossification variants or normal other variants in order to make sure that the patients do not get treatment, which is not necessary. So let's start with the first one, which is acute trauma, as we see quite often. So children are different compared to adults. They have growth plates, and these are places that are very vulnerable to injury. So we all know the Salter-Harris classification. There's 5 types of them, and there's quite an easy mnemotechnic just to remind this. This is Salter, where in Salter-Harris 1, we have a slip of the growth plate. In 2, there is a lesion above the growth plate. In 3, it is below the growth plate. Type 4, Salter-Harris lesion really crosses the growth plate, so it goes through the growth plate. And in the rare case of Salter-Harris type 5, we have a crash injury, and thus the growth plate is ruined. So from type 1 to 5, we can see this mnemotechnic Salter, which makes it really easy to remember. Good, so let's start with some radiograph examples here, and they're quite easy to depict. We start with the Salter-Harris type 1. It looks really dramatic, as we can all appreciate. Then again, this one will heal very well. We have to fix it in place, but then we know that this lesion will be okay. It's a quite rare topic, with only 1% of Salter-Harris type 1s. The most common by far are Salter-Harris type 2 lesions, which basically extend from above the growth plate and they stay at the metaphyseal side of the growth plate. So they do not cross the growth plate itself, and that's why they will heal pretty well as well. So Salter-Harris type 2 lesion is okay too, and very common. From type 3 onwards, type 3 is below the growth plate, but also a bit through the growth plate. And then type 4 and 5, they are more dramatic and they often need surgery. So how does this look like on MRI? On the left, we see a Salter-Harris type 1, which can be dramatic, but sometimes can be really difficult to see as well. What we can see in this patient is just a asymmetric widening of the growth plate itself, but the growth plate itself is still intact, so we know that this lesion will grow out quite well. Type 2 lesion, we can see it coming from above and it stays on this side of the growth plate. It's very common. And then type 3 is more complicated already. It comes from the joint, it's from the articular surface, and it goes all the way up to the growth plate, and then it crosses along the growth plate. So that's a type 3. Now, the most difficult and the most dramatic ones are types 4 and 5, where we really have injury to the growth plates. And the result of this is that we can see bony bar formations, as we can see here quite nicely depicted. So we can see the growth plates on this fluid sensitive sequence quite well, and then here all of a sudden it stops, and there we can see it back again. So this is what we call a bony bar. And these bony bars, they are, well, a bit annoying, because if you only have them on one knee, then you can get growth disturbances like leg length discrepancy. So the surgeon might want to do something about this, like a bony bar resection on the affected side, or maybe an epiphyseal on the non-affected side. Now, in order to do the bony bar resection, your surgeon will want to know exactly how big and where this bony bar is. So he may request you to map this, and then a 3D gradient echo image like you see here depicts this bony bar the best. Good. Let's move on to the next entity that we can see sometimes, which is the lateral patellar dislocation. In this older child, we can see that there is this typical lateral patellar dislocation. And I show these radiographs because, well, even here it's, well, obviously you can see that the patella is on the lateral side, but quite nice also is that since the patient is laying down anyways, if you would do a lateral, then you could see a fat fluid level, which is quite nice. But this is about MRI of the pediatric knees. So this is how it looks like on MRI. So typically we see kissing lesions of bone marrow edema, both on the patella and on the femoral condyle. So here we see them. So typically you see them on the lateral aspects of the femoral condyles and also on the medial aspects of the patella. Also really important to check the medial patellofemoral ligament, because this may be torn in these patients. And as we all know, especially in children, very often we get, this is just a temporal dislocation which reduces spontaneously. So children may come in with their patella at the right side. This is how it looks like on the sagittal. So we have, again, kissing lesions of bone marrow edema on the patella and the femoral condyle. It's a very typical appearance. Once you see it, you'll never forget it. In acute trauma, we can also have an acute patellar sleeve avulsion, like we can see here. So there is this tiny sliver of bone. Obviously, we cannot see very well on the MRI, but we can see that there is bone marrow edema at the most inferior aspect of the patella, and this is the patellar sleeve avulsion, sometimes a bit confused with Sinding-Larsen-Johansson, which is also a lesion that can be seen at the same site. But so really easy to depict on the MRI because we have the bone marrow edema. On the radiograph, we can see a sliver of bone. If, of course, there has been ossification of the patella already. Otherwise, sometimes in younger children, we have a lot of cartilage, but not a lot of bone. And in these patients, it can be really difficult and really easy to miss chondral fracture. So this is another example of such a chondral fracture. We have to keep in mind that the cartilage, of course, is translucent on radiographs. And in children, there's a lot of cartilage. So if a child presents with knee pain, maybe grinding or locking, and then the radiograph is normal, then it might be still a good indication to move on to MRI. And here we can see this very, very large chunk of cartilage in the weight-bearing part of the femoral condyle, which is seen at the most anterior aspect of the knee. So you would not be able to see anything apart from maybe some joint effusion on the radiographs, but MRI is really mandatory in these cases. We're still dealing with types of acute traumatic lesions, and we have to keep in mind that children are not the same as adults. In children, the ligaments are so much stronger than the bone which is still maturing. And one of the typical things that we can see then is that there is a tibial spine avulsion. Here you can see a small piece of bone at the side of the tibial spine, and on MRI it looks like this. So we have an avulsion of the tibial spine. There is some surrounding bone marrow edema, and when we have a look at the ACL, we can see that this is perfect. This is just intact, whereas of course in adults very often we would see it the other way around, with an ACL tear first. So that was acute trauma. Let's move on to overuse injuries. And there we have osteochondritis dissecans, which has been discussed a little bit in the previous presentation by Bert Degrieck. So osteochondritis dissecans is due to repetitive microtrauma. It is a disease of the subchondral bone plate, and this is why we can see that this is a very broad, a very wide lesion. So there is no sharp angle, but this is very wide. This would measure more than 105 degrees. So this for sure is an osteochondritis dissecans. Now, what does the surgeon wants to know? So firstly, of course, he wants to know if there is an OCD, yes or not. But probably even more important, is it stable or is it unstable? Stable osteochondritis dissecans will be treated by non-weight bearing, whereas in cases of unstable OCD, surgery will very often be the way to go. So can we help differentiate them, whether this is stable or not? Well, of course we can. We have a few criteria which apply especially for pediatric knee. And if we see a large OCD, like we can see here, it's in the middle and posterior thirds of the femoral condyle. And there is probably at least one fracture of the subchondral bone plate, which is better seen on T1 or PD images. But then also there is this high T2 rim, which is filled with fluid signal. So this really is joint fluids, which is seen as a rim surrounding the lesion. Or when there is multiple small cysts surrounding the lesion, or one large cyst that is larger than 5 millimeters, then these are signs or MRI features of instability of an osteochondritis dissecans. So that's something that we should really report. Are there fractures of the bone plates? Is there a high T2 rim with fluid signal, and are cysts present surrounding the lesions or not? Also keep in mind that it's important to check whether there's loose bodies, and they may occur in stable but also in unstable osteochondritis dissecans. So the surgeon will want to know the number and the localization of these loose bodies for surgery. Okay, this is going quite well and fast, I hope. Let's move on to infection, because that can occur also. And so when we are imaging, when we do MR imaging of acute septic arthritis, this is the image that you should be looking at. And I am aware that you are looking at a black screen now, and that's simply because in these cases, there really is no time to waste. There simply is no role for MR imaging. If a young patient presents at your department, at the emergency department, with a solitary, red, swollen, and painful joint, then if there is any suspicion of septic arthritis, then ultrasound-guided aspiration is the way to go. If we would do an MRI in the acute phase, which we do not do, but if we would do it, then it would look something like this. So you get to see some edema, bone marrow edema, which is very ill-defined. There is a relative lack of fluid in the joint, quite surprising. But what you typically see is that there is inflammation of the soft tissues surrounding the joint, and this is typical for acute septic arthritis. The better way to go indeed is to do an ultrasound guided aspiration, and this is what we would do in clinical practice. Later on, if we do an MRI, then we can see sequelae of septic arthritis when the disease has healed. Very often we will see multiple small osteochondral lesions, typically seen on both femoral condyles. And there is the bony bar again. We can see bony bar formation in these children. As you can see, let me go back to the previous slide. We can see that there is quite often bone marrow edema also in the epiphysis, also in the metaphysis. The growth plate may be infected too, and so this quite often results in these type of bony bars. We all know the subacute osteomyelitis or Brody's abscess, which we can see in the metaphysis, and there is quite a bit of bone marrow edema surrounding this lesion on the T2 weighted sequences, and there is some enhancement after we administer contrast. And of course, when this infection is laying very close to the periosteum, like we have in this patient, then we will see the soft tissue inflammation and enhancement again. So this is the subacute infection. And then one last type of, so-called infection that we may occur is CRMO. In CRMO, we can see that there is bone marrow edema, especially at the site of the metaphysis, in multiple joints on multiple times. So CRMO, the words, it states what it is. It's chronic. So this entity may be present for like a few years. It's recurrent, which means that the disease will disappear and the pain will disappear, but there will be flares, which can be weeks, months, or even years later on. It's multifocal, so we can see it typically near the knees, near shoulders and ankles. And it is a type of osteomyelitis, but if we would biopsy this, then we cannot find any bacteria or anything there, because this is an autoinflammatory disease. It's a kind of autoimmune spectrum disease, which has more to do with rheumatic diseases as opposed to infection itself. All right, so next category of lesions that we can see on MRI of the pediatric knee are tumors. Of course, there's a lot of things that we can tell about tumors, but I'll just stick to the basics or something that I find really important. And that is, in children, we have to be aware that the tumors that we're going to see are a little bit different compared to adults. And so the ones that we will see most and that are malignant are the Ewing sarcoma and osteosarcoma. And it's quite important to try to differentiate both of them. And what is really important is when we look at both of these figures, both of these images that we can see here. I mean, I'll give the people watching the slide 10 seconds in order to decide for themselves which one is the osteosarcoma and which one is the Ewing sarcoma. So I hope you just made up your mind, and let's go through these images together. So here in pink, we can see that there's a lot of new bone formation. This is bone. Whereas on the other image, we can see a lot of small blue cells pretty much everywhere. So this on the left was the osteosarcoma indeed, and on the right we have a typical Ewing sarcoma. So the hallmark of these tumors in case of osteosarcoma is the bone formation, whereas in Ewing sarcoma we have got a lot of cells. And this, of course, we will see on the MRI. So this is a very typical tumor. It's in the metaphysis. It's quite typical for an osteosarcoma. And so they will show a lot of new bone formation. So we can see that the bone itself is really dark because of the bone formation, but also in the mass, which, well, there's this massive mass which is extending out of the bone contours, but within this mass we can see that there is these very, very dark regions, and these of course are regions of new bone formation. So this is osteosarcoma. Another example, here we have a patient with osteosarcoma of the fibula, and it's not very hard to appreciate that there is this very large new bone formation present in these patients. Now, a problem that we as radiologists will have to deal with is that in this patient, this mass will not shrink with chemotherapy, even though chemotherapy is doing its job. So it's our task, our duty, to try and find ways to see whether chemotherapy is doing something good for our patient or not. And there is a nice trick to do this, and this is dynamic contrast enhanced imaging. So basically, we just pick an actual slide through the tumor, and while we administer contrast, for every second for like give or take 120 seconds, we will make sure to image this slide. And then we place two ROIs, region of interest. So we will place a region of interest on the most enhancing bits of the tumor itself. And for comparison reasons, we will also place a ROI at the site of normal adjacent muscle. And so this is a typical type of curves that we will get. So the normal adjacent enhancing muscle is the line that we can see here. So there is this slow but steady enhancing muscle tissue. On the other hand, we can see that the most active part of the tumor does show a very steep increase of signal intensity. Hence, there's a lot of feeding arteries, so the perfusion is really high. And we can see even later on that there's a lot of contrast still going towards the tumor. Now, if we would repeat this, let's say after 3 cycles of chemotherapy, then what we hope to see, if we do exactly the same type of imaging, then we hope to see that there is this altered shape of the curve of the most enhancing part of the tumor, where the first part or the first pass of contrast is not as intense, is not as fast. So this indicates that the perfusion of the tumor is decreasing. And then we can also clearly see that the overall, the end vascularization of the tumor has decreased as well. So this may be very helpful for our oncologist in determining whether this patient needs more chemotherapy or not. On the other hand, we have Ewing sarcoma, and we have just seen that these are small blue cells. So at time of diagnosis, that's the image on the left, we can see that there is this soft tissue mass, whereas after 3 cycles of chemotherapy, we can easily see that there is a decreasing mass, so the mass shrinks with chemotherapy, and this is a patient that may benefit from further chemotherapy as it's clearly working. Good, let's move on to inflammation. So when we are discussing inflammation as MSK radiologists, we have to be aware that the clinician already knows, right? So the child on the left is a 2-year-old female, and well, have a look at the right knee. It's really easy for every clinician or parent or radiologist to determine that there is this massive swollen right knee. So they will mainly ask us to rule out internal derangement or try to see if there are structural lesions that may cause this type of swelling. Otherwise, they know that this is a patient with JIA. So the typical things that we would see if we do an MRI in these patients with inflammation, juvenile idiopathic arthritis. So the typical things are obviously joint effusion. When we administer contrast, we can see that there is this thickened enhancing synovium, so there is synovitis. But something that's quite nice that I would like to point out to you is epiphyseal cartilage hyperemia. So when we have a look at the epiphysis, we can see that there is a very, very intense vascularization there. And this is really typical. This is hyperemia. We can see this on MRI for sure, and it's really nice, but we can also see this on ultrasound. So this is a patient that we scanned a few weeks ago. This image to the right is the normal knee, which was not swollen, and you can see that there is a normal size of the cartilage. Whereas on the other side, this was the right side, we can see that when we compare both sides, there is a massive increase in size and thickness of the cartilage. And this is due to the hyperemia. The hyperemia will lead to rapid growth. And if we put on the power Doppler, as we did here, we can see the spoke wheel appearance of these large vessels, as we can see on the MRI just as well. So I like this feature quite well, epiphyseal cartilage hyperemia, and especially the fact that you can see it on ultrasound, I find very neat. Later on in the disease process, we can see small erosions in patients with juvenile idiopathic arthritis. Of course, there is a synovial hypertrophy, as we mentioned before. And also check for lymph nodes. Lymph nodes may be a sign of active disease. So go to the popliteal fossa and just check whether lymph nodes are present or not in your patient. Congenital and metabolic diseases is the next category of lesions of the pediatric knee that I would like to discuss. And the first one here is hemophiliac arthropathy. And again, your clinician will know, they know that there is hemophilia, so we can't surprise them by diagnosing this. But what they want to know is two things. Firstly, they want to know, what about the structural lesions? So the problem with these patients is that even though they get their therapy, they get their von Willebrand factor and all these type of fancy medications, still sometimes there will be bleedings in the joint. And these bleedings, they cause structural lesions like erosions. As you can see here, there's quite a few erosions. There's obviously the synovial hemosiderin deposition, because the synovium will eat the blood, so to say, and because of the inflammation, it'll hypertrophy. So they want to know, well, what is going on with the joint itself, the structural lesions, is this still a good joint, or is there a lot of damage already? On the other hand, the question may be if there is a recent hemorrhage or not. And if that is the case, then, and if you're scanning only with PD and T2 fat set like we normally do, then you may miss acute hemorrhage. So when they ask for recent hemorrhage, then you could add a T1 weighted image, just a classic T1 weighted image to your protocol, because there you will see your acute hemorrhage as high T1 signal. Good, and then obviously, because of the hemosiderin deposition, we can see the blooming artifact, which we all know quite well on the gradient echo images, like is really nicely depicted here. So the big black spots of blooming artifacts. Another congenital thing that a lot of patients present with is vascular malformations, and the most common of them being the venous malformation. And they do occur quite often adjacent to the knee joint. And you can see them. I mean, if you just look at a patient's knee and they will show it to you, there is this blue discoloration of the skin. And well, they're there, they've always been there, and they're more often than not a problem. But sometimes when they come too close to a joint, they have, when you really have juxta-articular venous malformations, then they can bleed into the joint just as well. So this is a 17-year-old girl. We can see that there is this typical lesion here. We can see that there's a few phleboliths here and there. There's septi within it. So this is a venous malformation, and this would not be so bad. But this is a patient who suffers from recurrent hemorrhages within the joint, and you can see in the 17-year-old girl how that this has led to the presence of erosions both in the femoral condyle but also in the tibia. Okay, and now it's up to the audience. I know that it's quite late, and I congratulate you for still being here. So it's my task now to wake you all up. And this is another lesion of the pediatric knee, and now it's up to you. I know that you've probably been reporting so much today, and you've seen so many cases, but this is one where I need your attention a bit more. So this is a 15-year-old boy presenting to our department with pain, because they all have pain, otherwise they wouldn't come. And we see this lesion. And I will give you 4 options here. Is this a venous malformation? Is this a hemangioma? Is this a mixed venolymphatic malformation, or is this none of the above? And there is a poll appearing now, and you can all vote. So a few more seconds. I hope everybody voted.
69% has voted up to now.
Okay, so 4 options.
Just a little bit more. 75% has voted. So, all right. Now, should I give you the results?
I am really keen to know the results. Yeah, for sure.
All right. Venous malformation, 5%. Hemangioma, 10%. Mixed venolymphatic malformation, 27%. And none of the above, 58%. It's up to you to tell us now.
Okay, that's really interesting. And so just before I give the answer, let's have a look at the lesion. So there is a lesion. It's quite close to the joint, but it doesn't appear to be within the joint itself. I do not see any septi. I can't see any phleboliths. And these are typical signs of venous malformation. So I would expect them, but I can't see them really. In case of hemangioma, so there we have a lot of arterial vessels with a very high flow. So I would expect to see some flow voids, but I can't really see flow voids. It's just a very homogeneous lesion. Option C is a mixed venolymphatic malformation, but this is a contrast enhanced image. So this is T1 fat set with contrast. I should have said that maybe. But I mean, that's, well, it's a bit of a tricky question maybe, but anyways. So it is not a mixed venolymphatic malformation. So what we are looking at is a wolf in sheep's clothing. Do you see the wolf? Here is the wolf. And that lesion is a wolf in sheep's clothing too. Because what we were looking at was none of the above, and this is a synovial sarcoma. So of course, these are the rare lesions that we have to be so aware of, and they may be, well, if we miss them, the patient will die, right? So that's why I just wanted to point this out again. So there is no septi, there's no phleboliths, there's no flow voids. It's a lesion close to the joint but not in the joint, and then we always have to keep synovial sarcoma in the back of our minds. Also know that this is the 3rd most common MSK tumor in children after osteosarcoma and Ewing sarcoma, so it's not so rare. Good. But the vast majority of the people in the audience had it right, so I congratulate you all, and I can tell you that a second question will be coming later on. So everybody has a second chance, or to, well, just to go home with a good feeling. Okay, avascular necrosis. We see the double line sign. We know this very well from adults. There is a T2 hyperintense rim, and the lesions are typically geographically outlined. Now, in children, more often than not, this is due to corticoids. So what we have is have very, very high doses of corticoids in patients with ALL or maybe with nephrotic syndrome. And this is the typical type of lesions that we see. We will see it in the knee, but also, as you know, in the shoulder, in the elbows and in the ankles and hips, of course. So moving to the shorter second bit of this presentation, we're going to deal with normal ossification and normal variance. Well, this is the case that we just saw, and this was very well discussed by our residents. So just to keep in mind, this is really important for the boy itself as well as the parents. If you state that this is an OCD, then the therapy is 3 months of non-weight bearing, and this really is a very big burden to the boy, but also to the parents. So you can make yourself very popular with the parents by making this diagnosis right. We have seen the different types. There's puzzle piece, partial puzzle piece, speculation, extra ossification center. We have seen nice examples of this. What I just wanted to point out as well, so Bert nicely discussed the presence of pre-ossification center and early ossification center. It's important to point out that this occurs within the cartilage, so not within the bone, but within the cartilage, which is about to ossify. So first we get this very sharply delineated region of high T2 signal, which is due to cell necrosis. So the chondrocytes, they will die off really quickly, and then later on you get the early ossification center, which is a bit bigger and becomes hazy, and then we will see that this bit is ossifying. So the most common ones that you will occur in your daily practice are the speculation at the posterior aspect of the femoral condyle. So again, it's in the posterior third, as was pointed out, and also the early ossification center. In up to 42% of patients with from a certain age, you will see this. And so the puzzle piece configuration in the posterior aspect of the femoral condyle, and especially no bone marrow edema, these were signs that this was an ossification variant. And well, you know that surgeons are very difficult indeed to persuade sometimes, so we had to do the repeat MRIs, but I think that we should be confident enough in order to make sure that these repeat scans are not necessary. Of course, the knee is not the only site where we will see this type of ossification variance. So you have this puzzle piece type configuration lesion in the capitellum of the elbow, and this is a type of osteochondrosis, and we call this Spanner's disease. And another example in the elbow, so this is the non-ossified cartilage of the elbow, and we can see that there is this hole, and this hole is just a normal pre-ossification center in the capitellum of the elbow. So they do occur everywhere, of course, not just in the knee. And then there's some funny things that we see in children that maybe, well, you may be a bit surprised about when you see them for the first time, but they're just normal, really. And the first one is the presence of red bone marrow edema, of red bone marrow. And we can see the red bone marrow in children as a flame-shaped type of lesion or structure, which typically reaches all the way to the growth plate. So this is just what we normally see, nothing much going on, but you have to see it, well, you have to know it in order to make sure that this is not a CRMO, this is just normal flame-shaped red bone marrow. A dorsal patellar defect is seen in 0.5% of the patients. It's a fusion defects of the growth centers. It's seen super external, but the overlaying cartilage is normal. So we can see on the radiograph there's this translucency which is increased, and then again on the MRI we can see that there is this dorsal defect. The overlaying cartilage is really neat, and there is no defect there. Bipartite patella, well, we see this pretty much every day or week, so it's more often than not superolateral. And there is a synchondrosis. You can see that really nice on MRI. So, well, these are growth centers that did not fuse well, meaning that in between we see this little bit of cartilage. So it actually kind of forms a synchondrosis. And when there's too much tension on the bony parts, then we can see some bone marrow edema here too, which may be painful. So even though you see a bipartite patella, that doesn't mean that the patient cannot suffer from pain from this normal variant. Okay, and then we're nearly there. Another case for you. Waking up again. So we have a 7-year-old boy who comes into our department because of knee pain. And I give you 5 options here. Is this an osteosarcoma? Is this a lymphoma? Non-ossifying fibroma? Is this a Brody's abscess? Or is this none of the above? So yet again, here we go. I like these questions because they give me a bit of time to relax. So take your time, please.
%70 voted up to now.
Okay, I guess we're nearly there. It's only
2
less than...
seconds to go. All right. So 1% for osteosarcoma, 2% for lymphoma, 17% for Brody's abscess, none of the above 23%, and 57% for the non-ossifying fibroma. What would you say?
Oh, this is really interesting again. So let's analyze the lesion. So it appears to be on the medial side of the metaphysis at the distal aspect of the femur. So in case of an osteosarcoma, we would expect a breach of the cortex. We would expect some periosteal new bone formation, which is not seen here. Lymphoma may occur, but it's typically seen in the middle aspect and not really at the medial aspect. And these children, very often they are sick. They are really, really sick, and they don't come in through the emergency department, but they are referred from another hospital where they, where the first diagnosis is made. Brody's abscess. Again, this would have to be a child with a specific history of, well, you know, of illness, of being sick, of not feeling well. And a non-ossifying fibroma is a very valid option. And especially in older children or in adolescents and young adults, this would be the number one differential to go. But this, what we're looking at here, is a very, very typical lesion in children, which is, well, which has got a lot of different names. And the most commonly used one is a desmoid tumor. So a desmoid tumor or a cortical desmoid is not a tumor, but it's a tug injury. So it's a tug lesion at the site of the origin of the medial gastroc muscle. And we see this all the time, every time. It's very often bilateral. So if you're in doubt, it's in about 90% it's bilateral. So if you're in doubt and you really feel at unease, then you could do a contralateral, and then you will see that your patient has got the same type of lesion on the other side. We can see this on MRI just as well. So there is high T2 signal in the bone itself, and also in the soft tissues adjacent to it. And this is the origin of the medial gastrocnemic muscle. So again, it's very often bilateral, and it's not to be confused with malignancy. On the axials, we can appreciate this even better. So there is this typical high T2 signal in the bone and the soft tissues at the site of the origin of the medial gastrocnemius muscle. And so this is so often seen in children that you should not be afraid that there is some nasty process going on that side, especially in young children aged 7 to 10 years old. So last entity that I would like to show you, because I thought it was a quite interesting case, and is the first case ever that I published so many years ago. This is entrapment of the popliteal artery. So what we can see here in this child is that there appears to be an aberrant slip of the medial gastrocnemius muscle, which runs in between the popliteal artery and vein. And on MR arthrography, we can see that this aberrant slip causes this kind of focal indentation in the artery. And I like this case because the popliteal fossa, or the posterior aspect of the knee, is something that we always tend to forget. So I try to teach my residents, when they had a look at the knee, you know, all the typical structures, just make sure to go and have a look at the posterior aspect of the knee for making sure that you don't miss any subtle findings like this arterial popliteal entrapment and reporting. Good. So I'm glad that I have reached the end of this presentation, which is quite new to me because I'm talking to my screen only, and it's so funny to know that people must be watching and listening, but I can't see you. Anyways, you are home already, but take-home points would be that in MRI of the pediatric knee, in case of trauma, remember that there's a growth plate, and remember that there's a lot of cartilage, so things may be a bit different compared to adults. In osteochondritis dissecans, the surgeon wants to know whether the lesion is stable or unstable, and whether loose bodies are present or not. In infection, there is no time for MR imaging, so we go to ultrasound straight away, but we can see sequelae, we can see Brody's abscess in the metaphysis, and CRMO is an entity that may mimic infection. In case of tumor, the location is really important, and think of using dynamic contrast enhanced MRI to assess the perfusion of a lesion. And there is a lot of variance, as were discussed by Bert and myself. So there's ossification variance, and also keep in mind that the cortical desmoid is not a nasty tumor, but just a normal variant that we see quite often. So I thank you very much for your attention. There is some references for you, and I am ready for any questions if you would have any. Thank you.
Thank you, Dr. Jans. That has been really a great presentation of a very interesting one. So please, we have time for a few short questions. Please use the tool to raise your hand and ask questions to the speakers. I see no raise hands. Is that correct, Ricarda?
I think we have 3 questions. I will unmute Dr. Ume Sarah Zischen.
Okay.
If you can, please speak.
Hi there. Thank you for this great talk. It was really amazing. Just had one question for to differentiate a soft tissue mass like the one Professor Jans showed us on ultrasound, to differentiate a vascular malformation from a fat containing probably sinister kind of a mass. In synovial sarcoma, obviously there would not be any fat, I expect, on ultrasound, but are there any features that he would say that would definitely differentiate these two?
Okay, thank you very much for that question. Now, my experience is that especially in children, if you see a soft tissue mass on ultrasound, even though it's very well delineated and it looks nice, then
Mm-hmm.
then there's still well, we call this whoops lesions sometimes. I mean, and these are the type of lesions that are reported as being venous malformation or lipoma or whatever type of soft tissue lump, but
Mm-hmm.
get into our hospital, which is a university hospital, and we call them whoops lesions because they turn out to be synovial sarcomas. The
Okay.
problem with these malignant tumors in children, soft tissue tumors in children, are that they look really nice and neat and well defined, well delineated on ultrasound. So we had more than a few cases where the final diagnosis differed from what was seen on ultrasound. So to answer your question, I do not think that there's a typical sign or feature on ultrasound to differentiate just well non-malignant versus malignant lesion. And in children, I think you can't take the risk.
So
So I should move forward to MRI.
MRI. Okay. Contrast enhanced MRI. Okay. Great.
Always advanced MRI for sure. Yes.
Thank you.
Now you have Dr. Jans, you have thank you and congratulations from Dr. Goran Juricic, if I pronounce the name correctly. And then I would like to give you the question from Roar Pedersen from Norway. First of all, he congratulates you for the lecture, and then he asks, are the ossification variants more usual at the lateral or the medial condyle?
Well, that's a good question, and I have to be honest, I don't recall exactly. I will have to look this up. I wrote a paper on this a few years ago, but what I do recall is that I saw it all the time, everywhere. So I think that there was a small predilection for the medial femoral condyle, but I'm not 100% sure here. What I do know is that in some age groups, and this is something that might be interesting for the audience to point out, especially when children are aged 4, 5, 6 years old, and then in more than 50% of these children, you will find these ossification variants. So do not panic when you see them, especially in children younger than, let's say, 6 years old. You're never ever gonna have an osteochondritis dissecans, but you will nearly always see um, some type of ossification variants. But I would have to look up to see whether the medial or lateral aspect is more prone. And I promise to Dr. Peterson that I will send him a personal email verifying this information.
Okay, thank you. Now, congratulations, or rather, thank you from Dr. Christine Swettens. And then, Ricarda, do you see any other questions?
Yes, we have one more question from Dr. Mohamed Hosameldin. Did the CRMO could mimic focal peripheral edema zone?
Well, CRMO is quite a typical entity. So in these patients, we will see that there is bone marrow edema in the metaphysis on multiple sites, especially at the time of initial presentation. So these patients come in because they still feel sick, they feel at unease, and at that time, MRI might not be the first imaging modality. So quite often these patients go in for a bone scan first, even though they are children. And there you will see that multiple metaphyses are affected, and they might ask us to do a more specific MRI scan of a certain region in order to rule out for sure that this is CRMO. So it's such a typical entity that I do not really think that there is confusion possible with a solitary peripheral bone marrow edema region.
Thank you again. I would really like to conclude the session now and say a great thank you to Dr. Bert Degrieck. I would really like to say a great thank you to you, Lennart. It was magnificent tonight. I would like to remind you that the next webinar, I would like, of course, to say thank you to all attendees tonight who stayed till that time with us now, and I would like to remind the next webinar, which is going to be on Monday, February 11. It is going to be with Professor Carlo Martinoli from Genoa, Italy, and it is going to be related to MSK ultrasound. Thank you to all of you. Have a good evening.
Bye. Thank you all.